tell us about the latest developments in the treatment of brain tumours.
Well, it's an unfortunate thing that even though the incidence of brain tumours, and particularly these highly malignant tumours, have been increasing, in fact, they've increased probably by 40% since 1990 in the United Kingdom. So we're getting more and more of these tumours. And this is why we've taken an interest in the mobile phone computers, because we know radiation may be a causative factor. But so we've got an increased incidence, which we don't quite understand. But of course, this may be because we're diagnosing more of them, because people are more conscious of going to their GP, and when they get to the hospital, to A&E, it's diagnosed, or it may be that the doctors are saying, oh, we can do something. So we've got more, whether it's a true increased incidence, which I believe it is, and we all believe it is, but there's certainly a greater number of patients being diagnosed and treated. Now, in spite of that, and we have improved survival from months to an average of about 1.5 years. So, but that is not good enough. And now it's quite interesting. The incidence of brain tumours has increased more in women than men. And that's primary brain tumours, these highly malignant ones that I've been chatting about. So higher incidence of men, higher incidence, it increases every year. So people are now taking an interest. What is going on? And we've got the brain tumour research campaign, the cancer research campaign, Macmillan. They're all now saying, we'll look at these brain tumours. Up to now, it was a very, very underdeveloped research area. It was from the area of even the surgeons. The surgeons were not too keen to operate on brain tumours. They would leave them and send them to the radiation therapist or give up. Now, one of the big improvements is what we call debulk surgery, that the surgeon will really go for it and try to get to the edge of the tumour. And if it wasn't for this complexity of this tentacle-like invasion, this would be the cure. Surgery is always your first arm of treatment in any cancer, and it is in brain tumours. So that's your one advance. Your second advance is in radiation therapy itself. The way we can give the radiation therapy with newer techniques, one of them is called intensity modulated radiotherapy, where we can focus the radiotherapy with a small margin round the tumour and leave the rest of the brain out of the radiation field altogether, has been amazingly important, because we get less side effects, we can go to higher doses, and so this has been another advance as radiation therapy technique has advanced. The third thing, drug treatments, drugs such as temozolomide and other drugs in recurrent tumours, which deal with actually on the blood vessels of the tumour. One of the drugs is called Avastin. This has been an improvement. So there's been an improvement in the whole approach, and definitions of this. We've defined these approaches more, and we've refined these approaches. For instance, in radiation therapy, we've got now stereotactic radiotherapy, where we can just zone in just on part of the tumour, or we can give a little bit higher dose to the tumour because it's safer. So these things have improved, And there's research going on all the time in each discipline, in surgery, looking at the edge of the tumor by various techniques and knowing when to stop. And another big improvement is some of the patients are operated on while they're awake. We call this awake craniotomy. And doing this, the surgeon can keep asking the patient, are they okay? So they know that safely they can go on and on removing the tumor. And an awake craniotomies are now commonly performed. So that's a big advance. IMRT in radiotherapy is a big advance. Drugs, chemotherapeutic drugs, as in all cancers, that's another advance. But now we're going further into actually analyzing in the laboratory what instigates, what makes these cells divide and become dangerous. What are the factors? Is it genetic? Is it biochemical? Is it environmental? We're trying to look at all factors. Now, brain tumors, and this is very, very important, do not spread out of the brain. They're the one tumor that stays where they are in 99.9%. People will say 99%, but it's probably more in my experience. They just stay in the brain. So if we could treat them in the brain, we won't get cancer somewhere else. And most people are aware that cancer spread to other parts of the body. And that's a very frightening aspect of most cancers. In the brain, they just stay in the brain because there's a thing called the blood-brain barrier, which the cells cannot cross. So that we know the brain is bathed in a fluid all the time, and it's got coverings, the meninges, and it can't cross. And there's no communication by blood vessels from these tumors into the rest of the body. There is from the rest of the body into the brain, but not the other way round. So we look at the cells themselves. Now we're finding extraordinary things. We're finding these cells need sugars. And we think sugars are an enemy, not only actually in brain tumors, but it's quite exciting that diet may actually not only prevent the patients getting unwell, but it may be even part of the cure. And a ketogenic diet where we're missing out completely these sugars seem to be a very, very important factor. So work is going on diets.
Is that like ordinary sugar?
Ordinary sugar, I would go as far as to say I think it's going to be proven to be an enemy. And
but we like it.
I know it is. I like it too. Although we know that we get one day in the papers, substitutes for sugars are dangerous and cause cancer. In fact, there's no absolute evidence for that. But we are getting evidence that tumors thrive on sugars. So this ketogenic diet in the laboratory certainly kills tumors in rodents and other cell lines. So this is really very, very important because we're living in a world now where people are talking about diet all the time, organic diets, whole vegetarians, for obesity. Now, there's no evidence that obesity and brain tumors are related, but that it is with other tumors. But certainly ketogenic diet we have to keep on looking at. Now, we do know that there are chromosomal and genetic abnormalities in these tumors. And we have to look at the genetics because the drugs we use are sometimes successful in one genetic type, where they have a certain chromosomal makeup and not in others. So this genetics of the tumor we have to investigate. And in fact, with a drug which I mentioned, temozolomide, it works in certain chromosomal types better. So we have to look at drugs in relation to genetic types, and that's what we're doing, and we have improved things. We have to look at the blood vessels, and this is what is another step forward. Now, there are other areas of research which we know that arginine, a substance found in these brain tumors, if we could limit the amount of this substance, we could, in fact, perhaps inhibit the growth. And there is work going on in various laboratories which, with the substance Adipeg 20, I won't go into the whole biochemistry because this will take another chat, but it's quite exciting research. I find it very exciting, this business of diet and sugars. If we would encourage, and it's so sort of quite confusing that bread, cakes, everything has these high contents of sugar. Now, I know government and everybody has now said, oh, they've got to put the content of carbohydrate, fat on all foods. It's sort of becoming government legislation, but I don't think people are aware how dangerous sugars can be. Now we're talking about brain tumors. It could be that sugars are dangerous in all cancers, but brain tumors particularly we have to look at. Now we're going then into other fields of research, immunotherapy, and there are centers using immunotherapy already in the world. Particularly there's advanced immunotherapy in lung cancer, but we believe it will be useful in highly malignant brain tumors, dendritic cell immunotherapy, where we actually push the immune system of the individual to gobble up these cells. Now, one can see how important this could be, because these tumors don't spread like other tumors to other parts of the body. So we haven't got to worry about what we call distant metastasis. If we could gobble up the tumor cells in the brain, we would win. This is why we've got these local treatments at the moment: surgery, radiotherapy, and chemotherapy. The chemotherapy, unfortunately, doesn't get there because of the blood-brain barrier. Having said that, the radiation does break down to some extent the blood-brain barrier, and some of the drugs get in, but very few. So we've got to go on looking for more drugs that will cross this barrier into the tumor. So really, we hopefully, now, can I just talk about in general, the funding of brain tumor research, it's more than it used to be. People are taking an interest, particularly in primary brain tumors. We haven't even discussed the more benign tumors or the secondary brain tumors. But in these primary malignant tumors, at last people are funding more research. There is an awareness, but we have to increase this awareness. And I hope by our chat, I will be increasing the awareness that we have to really study this tumor for many reasons, not only because it's lethal for a great many people, and there's an increasing incidence, so a lethal tumor, an increasing incidence, but because it doesn't spread to other parts of the body. By studying this tumor, we may extrapolate from it how to treat cancers as a whole. So I think it's a very, very exciting time to be around in this field. Thank you for listening. I hope you found this interesting, and if you did, please subscribe.